All right, we've got lots to cover today, so it's top of the hour for me. Good morning, Cindy. How are you?
Good morning, Dana. How are you? I'm good.
I'm excited to be here. Welcome, everybody. My name is Dana Trawczynski, and I'm the Senior Director of Clinical Operations here at Ignite. We're so excited to have this webinar for all of you today. The topic, Bridging AS Patient Identification with Clinical Action. Talking with Cindy, we really designed this session to be a practical, kind of peer-to-peer conversation. We're going to use her health system to really highlight how she used the technology of CardioCare along with her workflow optimization to really improve and make an impact on earlier identification of her aortic stenosis patients and kind of accelerating their care pathway. I'm very excited to talk about Cindy and brag on her. So all of you know, Cindy is a cardiovascular nurse leader at Nebraska Methodist Health System. She has a lot of experience across cardiology, from EP all the way through structural heart. And throughout her career, she's played a big key role in developing and growing advanced heart programs. What I love about Cindy most is she is a advocate for not only her patients, but about her program. So let's walk through a little bit about what we're going to cover today together. Cindy's going to start by sharing the goals of Nebraska's structural heart program and really what prompted them to take a look at CardioCare. She's going to walk us through her daily workflow in the platform, and kind of highlight this by sharing some really great patient stories with us. Then we'll take a look at their program results, including progress they've made towards the AHA Target AS goals, which are improving care from diagnosis to treatment. And we'll talk together about some changes that they've learned and made and lessons along the way, and we'll make sure we save some time for questions. A little bit about Nebraska. Nebraska Methodist is a medium-sized health system based in Omaha. Their structural heart program is very well established, as you can see here. They offer a variety of full range of structural heart interventions, and they've built a really strong relationship in the area, in the state, in the whole region for really giving high quality care. So now that we've learned a little bit about Nebraska and a little bit about the background of Cindy, let's get into it and let's talk. Cindy, when you started looking at CardioCare, I think about you all the time because I previously was a valve clinic coordinator and started a structural program, and there's just so many things to think about when looking at CardioCare and looking at your own program. So when you started looking at all of this, what were some of the challenges that you were looking to solve? What kind of goals did you set for yourselves?
Yeah, thank you for the introduction, Dana. Some of our challenges and goals when the program is approximately about 7 to 8 years old, and some of our delays were showing up in our referral to treatment time. So we wanted to shorten that gap. And then we also wanted to identify these patients earlier and in a more timely fashion and give them a straight line access to our structural cardiology department and be seen quicker and sooner. And then you don't have to go through the roundabout process of, a delay here, a delay there. So that was a couple of our goals. But the big one is decreasing our referral time to structural heart team. And that's one reason we had started back in 2024 looking at different platforms that provide this service, and Ignite and CardioCare was one of them. That it just is very user friendly, has great support team. So the hospital system decided to go with our Ignite CardioCare platform, and that's when we brought you on in 2025. So we're approximately 9 months into the process now. So one of the goals, as I said, was to decrease that referral time, find and reach those untreated and undertreated AS patients, because they're out there, as every program knows. A lot of patients either get missed a follow-up, they fall off of their own follow-up, they don't come back in the 6 months or the year as recommended. So Ignite and the CardioCare platform allows us to find those patients and bring them back into your system and to streamline that referral process.
Can you tell us a little bit about doing all of that, how were you able to measure the impact CardioCare was really making on your clinic, on your practice?
Yeah. So, as a lot of valve coordinators know, Excel is your best friend. And that was
Yes.
kind of how we tracked everything from the date you got the referral, who it was from. But then at the end of the year, you start going back through that stuff. And as you know, it's not an easy process. Excel is finicky sometimes. So, the CardioCare platform, there's so many filters and it's so easy to basically create your Excel. It's right there in the platform. And then it creates lovely pie charts for you. You can find where the gaps are in your identification of patients, what areas you're looking at, because we do have some outreach. We also here in Nebraska, we're right next to Council Bluffs, Iowa, and we have a hospital system over on that side. So it helps us kind of keep that care compact and streamlined without having to dig through your Excel for hours and hours on end. At the end of year, when you're doing your yearly review of your numbers and your data. So that allowed us to look at our impact when we started this system. Because you can basically, you put in these filters and the system shows you are, you know, 70% grabbing most patients, 80%, or your gaps are in this, area of town or this provider. So it gives you that ability to reach out directly to that provider or that group and say, hey, we can get your patients back in sooner than later. Let us see them. Let us continue their follow-up for you and take that off your plate, especially with primary care providers.
Yes.
So that is a very measured impact that you can show. You can also show your reduction in your referral to your treatment time. And then as the program got moving, it got going with Ignite and CardioCare, and I got more comfortable with it, that's when we brought in the American Heart Association. And that shows then how you're capturing these patients and what your percentage is. So that was really, the platform makes that easy.
That's awesome. I think it's one of the questions I get a lot is I have something in place. Where do I start? What do I look at? What do I do with all of this? Can you take us all the way back to the beginning and tell us a little bit about what your process was before you started working with CardioCare?
Yeah. Before CardioCare, it was myself, as a lot of valve coordinators are, you're alone. So keeping up, we would basically look through our cardiac clinic, whether it was our providers for the structural or the general cards providers, and kind of look through these new patients because they're, easier to find. They have the 30-minute blocks and look at them like, they have severe AS. Well, they don't need to see general cardiology right now. Let's detour them into our structural program. But then you got to reach out to that cardiologist, find out, is that okay? Are they comfortable with that? And they're always like, yeah, sure. Then throw another new patient in that spot. So that is a very slow process. You do it every week. You'd have to dig through a couple of weeks ahead of time, especially if they're coming from primary care, because then you got to look back through your EMR to say, when was that echo? When did the primary refer? And in doing that, we realize sometimes when a patient has an echo, then it's read, and then the primary gets the report, and then they come to cardiology, that can be almost 2 to 3 months out. And as you know, with these severe AS
That's a big delay.
patients, yeah. And the big thing is, as we always say in the structural world, is we have to catch them in that window, that
Yeah.
window where they're somewhat symptomatic, but they're not falling off that cliff. Because you see those patients that have been sick for months and they're just kind of lagging in, and they're like, oh, I don't feel that bad, but their valve shows they are that bad. So in that delay, because then it took another, month, 2 months to get through our process. So now you're almost 6 months out, and the goal is 18 months. Most, the data shows 18 months that these patients will fall off the cliff and end up in acute heart failure if they're symptomatic. And then with the American Heart Association, the guidelines are, referral to treatment in 90 days.
Yeah.
So with that push by American Heart Association, that's how we pulled in Ignite. So that detour now is slowing. It is minimizing that.
And can you tell us a little bit about When you started working with CardioCare, how did you start to bring it into your clinic today, and what does that workflow look now?
Yeah. So when we brought in CardioCare, you have an initial, we call it a dump. We had about 300, I call them buckets. So the platform uses simple English language from your reports. That report is then put into a bucket. If it meets the criteria of severe AS, you go through that bucket and you have unreviewed AS patients that have severe AS per echo. Your initial dump is overwhelming, no joke. I think I had 300 on my initial dump because it goes back, I think, 2 or 3 years. And you just have to break that up into little chunks. So
Yeah,
every week I would do a half hour at the beginning of the week, a half hour at the end of the week. And
just to
you
start
get,
digging through it.
yeah, and you just break it up into small pieces, and then you also get, the more you use it, the platform gets easier to use. And since we've even started 9 months ago, the platform has updated significantly and make it a lot more user friendly and more data that you can see within that platform. So you're not going between two systems, your EMR and CardioCare. So we incorporate it now. So now we initially every week we probably get 4 to 10 patients that meet that severe AS criteria. So on Mondays is our dual structural clinic. And then in the afternoons, we spend about half hour to an hour reviewing those patients that dumped in overnight from the weekend and from the week before. And then you pull in, you look through it. And so creating that process has made it just part of your workday, becomes routine, just like we did before, digging through clinic. So now it's just more streamlined, doesn't take as long. So we do that every Monday. It's myself now. We've just added another valve coordinator because we've increased our volume. And we also have a nurse practitioner now. So between the three of us, we get to that on Mondays and then start doing our referral outreach, which is amazing. It's created such a straight one-to-one conversation with providers, whether they're cardiologists, primary care. At first, we were a little tentative because you're like, as a nurse, you never know how people are going to take you reaching out saying,
Respond to
hey,
you, right? Right.
yeah, your patient's meeting guidelines, would you like them seen? And it has been very receptive, especially with our primary cares. Uh, we've gotten more and more referrals from primary care. They'll get the echo and you literally are reaching out that week after that echo. And they're like, yeah, please get them into clinic. Please get them to clinic. And we always tell them, we're going to establish CardioCare at the same time. We'll do the workup at the same time and we'll keep you in the loop. So just building it into your weekly practice has streamlined it and made it easy to implement.
I want to talk a little bit more about that conversation because I think I get that question a lot is you said it, what is the referring provider, how are they going to react when you tell them about this patient that they're caring for, right? And your intention is you want to get them the best care and get them in as soon as possible. But there could be that perception of, why do you know about my patient? Why are you calling me? Who are you? So tell us a little bit about, like, what did you do to prepare the physicians around you that this was coming? And then how did you have that conversation? Tell us a little bit about
Yeah. So when we initially started using CardioCare, our structural provider, we started doing some lunch rounding with our primary care
that.
offices within our system. We would stop in their office, kind of introduce ourselves and let them know that we're going to be, reviewing echoes. So if you order an echo and you see us reaching out, this is what it's about. We're trying to capture these severe aortic stenosis patients within a good time frame, and also to establish care. Even if they're moderate to severe, we will get them into either general cards or us to establish care. And so we did rounds after that. And as we were building the platform and building it into our practice, we did that. So that was very helpful. And then also within our weekly, heart conference, we call it Team Heart Conference. Some people call it their structural meeting. We
Mhm.
have our general cardiologist there also. So we kind of gave them a heads up, like we're pushing to, follow American Heart Association guidelines and get these severe AS patients treated in a timely fashion. And even if they're being seen by you, if there's anything we can do to speed the process, let us know. So if you see us reaching out via EMR or even a conversation, because we're in the same clinic as them. So that was initially, it's very kind of nerve-wracking because you're not sure how they're going to take it. But it's been very receptive. They actually know your face. They know your phone
Yeah.
number now. So
Yeah.
they're
It's like, oh, it's
reaching
Cindy
out.
calling.
Yeah. So sometimes they're reaching out like, hey, I just saw this guy today. He got his echo this morning. It's not in the system yet, but I
But I'm
want him to
letting you
see you
know
guys.
ahead of time.
Hmm. And then it's kind of fun because then on that Monday, that name pops up. You're like, I know who that is. And
Yeah.
so they're almost beating the system at sometimes, which is exciting because before it was weeks out, they'd
Yeah.
send a note to the scheduler would send a note to you, and that can take a week. So it's been great. So I'm glad we have brought the platform on, and it's also opened the line of communication to providers because I think they're more comfortable with you reaching out to them.
With you reaching out to them. One of the things you said a little bit ago was trying to catch the patients before they fall off the cliff. And I think as a clinician, talking, with other clinicians now, that's the key, right? Is just being more proactive and trying to catch them well enough before they get to the table, right? Like you want to catch them in that window. So you've got a couple great patient stories to share with us, of which that happened. So tell us a little bit about Al.
Yeah, so this was one of our initial dumps of those 300 patients. This gentleman, Al, we'll call him Al, he's an 80-year-old gentleman. He had an echo done, diagnosed with severe AS on that echo. So the plain report, the English language is read by Ignite, the CardioCare platform, and then puts it into that bucket for you. So and then the platform itself actually gives you all the details from those reports. So it's not just the numbers that you're looking at on the platform. You're also looking at the report, the plain English report. And now you can look at the patient's history, the symptoms show up on the platform.
Mhm.
So this guy dumped in on his initial echo. CardioCare flagged it. And then his primary care had referred him to general cards for severe AS. So that referral goes to our general scheduler. So we don't see that. And he was scheduled about 2 months out. So this is a month from his echo. Now he's scheduled, but now he's 2 months out to see general cardiology. So CardioCare identified him. We reached out to the primary care and said, would you mind? He does meet the criteria for severe AS. And we see that you had sent a referral to general cards, and we have a structural clinic that we can get him through the evaluation process and decide, what's his best treatment algorithm, is it, whether it's TAVR or SAVR, or a watch and wait. So by the time we got him through the evaluation and seen, he would have only just started seeing general cardiology, and he was treated with a TAVR.
Wow. And
Yeah.
I think this
So,
is not unique, right? So what do you think
oh,
would have happened to him if you hadn't been flagged by CardioCare?
yeah, he would have seen general cardiology and then probably another month to get into us, because, by the time we get the referral, we're probably a week or two booked out. So that's another 3 weeks. And this guy, in the meantime, his symptoms could have gotten worse. He could have ended up in the hospital with acute failure.
Yeah.
And maybe even lost a follow-up because he might have decided, well, it's taken 2 months to get to this cardiology, and shopped around because
Yeah.
Omaha does have multiple systems in it and are competitive. So
Yeah.
this for us, and then once the primary said, go ahead, call him, we called him. He's like, so I can be seen in a week? We're like, yes. He's like, yes, please,
Bring me
because
in.
yeah, as you know,
Right.
once patients know this diagnosis, that's all they think about. And then they start Googling Dr. Google, and you're
Right.
like,
We don't want that.
yeah. So it's also a good way for us to talk to the patient and say, here's some reputable websites. If you want to read information, go to American Heart Association, ACC. We use a couple different ones that we refer patients to, and this is the
Yeah.
safe, true information that you want to read and before you come to us. So it allows us to also do that initial contact with patients earlier and sooner and get their trust. And that's a huge
Yeah.
part of getting people through this process. As you know, it can take weeks. Sometimes you have bumps in the road, but they know they can call you directly, So it kind of settles them to that they're not going to have to wait 2 to 3 months.
Yeah. And I think as nurses that it takes that's a lot of our time, right? Is education and making sure the patients feel comfortable and making sure they understand what's ahead of them and what are the decisions they need to make, right? So the sooner you can get just having an initial conversation with them, right? I think it just puts them at ease that they know that they're going to be, really well cared for throughout the process. You have another patient story where they were on the verge to being lost to follow-up. Tell us about that one.
Yeah, this gentleman, he had seen, I believe it was cardiology, but he never returned. It had been a couple years. So his primary got an echo, talked to him in the office, said, hey, maybe these are some symptoms of your heart valve, because he was a little fatigued, but not extreme, a little tired, slightly short of breath, but still doing his daily activities. I think he might have been still mowing, but very active, traveled a lot. So CardioCare identified one of his old echoes because the initial dump was from the past 3 years.
Yeah.
So in looking this patient up, we noticed, oh, well, he just saw primary and he just ordered a new echo. Patient gets the echo and we reach out to primary and we're like, hey, do you care if we get this patient seen? And he's like, yes, please. He's, doesn't like to come back to that doctor's and doesn't like to see us. I'm like, well, we'll try to make a connection with him and get him to come back.
Hmm.
And so we did talk to him, but he was traveling. I think he was going to like Tokyo or Japan. He's traveled a lot. Even getting his TAVR done took a while because he did travel internationally. But yeah, he came back after his last trip. He saw us in the structural heart. We evaluated him. He did have severe AS, worked him up, and then he got his TAVR. If he hadn't had that delay, that would have been within a month or two. But yeah, he felt good. He traveled a lot, but that was his priority. So, but it was neat to see, even with that initial dump, to see an old
Yeah.
echo, that primary was actually getting him back in and getting another echo, which is what we would have done. So it made a good initial communication with that primary and that patient.
And I think it's a good example of, we're all doing our best. We think we know about everybody in our communities and in our populations, but it isn't until you've got data in front of you that you can see, like you're saying, an older echo
Yeah.
where, you're bringing someone forward who may have, been missed out to treatment. So, it's a great example of how I think you take the human part of your experience as a valve clinic warrior, and you can't replace that, but you have a tool that just helps you do your job better, right? It gives you that visibility, and it gives the visibility. None of our patients just have aortic stenosis, so they have other things going on, heart failure, AFib, you name it. So, um, I love how you've just used this whole system with your expertise to just look for those patients and get them in a little bit sooner. Um,
Yeah. I
just
think
to show.
too, establishing the patients, if they have your phone number, your email, like we have a team email, even with his travels, if he had decided not to come back, we would have been able to keep calling him and bugging him because now we've established a communication line with him.
Yeah.
So, and a lot of these patients, it's trust. They have to trust you, especially if they're very hesitant. As you know, some patients, they, you can work them up and then they decide to wait and then they don't come
Yeah.
back. The CardioCare platform allows you to see those echoes even if they're not in your clinic, which is huge sometimes because those are the patients that just kind of lag and they don't want to do anything until they're very sick.
Hmm.
So
Hmm.
hopefully you can get them back in by then and convince them to come back.
Yeah. And I think as a coordinator, you wear a lot of different hats, right? You just kind of spoke to that a little bit. And it's hard when people would ask, what do you do all day? It's like, well, where do I begin? And it's sort of like, how do I show the credit for like what we're doing, right? So I kind of want to shift focus a little bit, as I was starting to say, and talk a little bit about what you've seen in terms of metrics and things that you can play back and say, this kind of shows what we're doing as not only yourself, but your program.
Yeah. So I know a lot of valve coordinators we use our NCDR to show your data. But that's just your post data. This is
Hmm.
what we've done. So like you said, showing people what do you do every day and how do you do it. This platform has helped us do that with one of our goals of growing our program. And be able to grow it, you need to find the time. And as you get busier, you lose that time, but Ignite gives you that back. So using the platform, we can show to our executives, to your management, this is the growth we're seeing. This is why we're asking for help, or this is why we need another, computer, or simple things.
Or another resource. Yeah.
Yeah. Or even big things, like we need more OR time. Well, show me why. This platform allows you to do that because it's showing you the pre stuff, whereas your registry, your NCDR is showing your post stuff, but you're still scrambling for time before you get to that. So this platform allows us to show the growth before you do the procedure. And that's what we are showing here is, so we were around 90 some TAVRs back in 2024. And our goal was to increase by, I think it was, we wanted to get 20%. We are showing a 35% increase in growth, and we are feeling it. And that allowed us to request, a nurse practitioner, another valve coordinator, because we could show this growth, not just via the procedure, post-procedure numbers. So this platform gives you those filtering abilities to show what you do every day in your work, because you can talk about it, but you got to show it. And that was hard originally for me as a valve coordinator, because I could talk for hours about what I do every day, because every day is different. But to show it on paper, to show your growth, that's where you get the support you need.
And what was the reaction from your leadership when you were able to put this together?
Yeah, once we started using the platform, and we could, you get that first initial dump cleaned out. We showed it at we have a quarterly meeting, and we showed this volume growth, and they were like, that makes sense to us, that to show that. Whereas, we're just saying, well, we did, 15 TAVRs this month instead of 8 or 9. You hear it, but they like to see it. So this shows them that this program is growing and it is sustainable over the next 5-10 years. And as we want to add more procedures, we can show why we're doing that. So it really does help identify with the executive level and the management level that you're doing your job and getting these patients seen and treated.
Yeah. And we started talking about how you've aligned with the American Heart Association and the Target AS initiative, and Nebraska is only one of 2 the whole state that are participating in this. So what did it take for you guys to become part of that? How are you using CardioCare? What have you seen in terms of that initiative?
Yeah. So when we brought out the platform, I had initially looked into it right before we brought on the platform, but the amount of work it would have taken, because it's just echo data driven. The American Heart Association gives you these guidelines for their inclusion exclusion criteria, but you would have to dig through your echoes and through your EMR and figure out how to set those filters. It would have been very timely and process. But with this, what we did is, so we reached out to American Heart Association because we had this platform, and kind of sat down with them, because most hospitals also are part of the PCI initiative, the Door to Balloon, which is part of American Heart Association. So if you already have that contract, this is just an addendum or an add-on to that contract. And then the American Heart Association also gives you a grant to be part of this study that goes through your cardiology department. So that was a huge initiative to use this platform to be part of this study and to show that we are reaching these patients. And that's what this slide shows, is the national benchmark, which is timely diagnosis. So American Heart Association and ACC, once a patient is initially diagnosed, and then you have 30 days to verify that diagnosis, whether it be, like, say they're severe, moderate to severe, asymptomatic, but you're doing like a DSE or, a CTA TAVR scan for your calcium scoring. That, once the American Heart Association is pushing us to do that within 30 days. That way you can truly diagnose and then get them to the referral. So that's your timely treatment, your referral to your treatment time. And the national goal is 75% of your patients that are initially diagnosed and then definitively diagnosed, you have 30 days and then you only have 90 days. So when I initially started doing the data, I was like, oh, I don't know. I was worried. I'm like, oh my gosh, I'm gonna have to show this to management and we're going to be way under. It just felt, but the CardioCare platform makes that so easy. You set these filters, you save these lists, and it didn't take me very long to do a whole 1 year dump because we were going back a year. And when this came up, an American Heart Association sent it to me, and I was like, oh my gosh, we are doing a good job. So
You were
as this
surprised. Yeah.
I really was, because when you're looking through your data, you're like,
Yeah.
oh, I don't know. And then you're like, oh, how do I present this if we're not meeting
Yeah.
I mean, that was my initial thought process. How do I bring this up in a positive light? But I was able to bring this up into our heart conference meeting and be like, and that helps show even your general cardiologist, we're doing the right thing. We're meeting these national goals. So if it
Hmm.
ever does become a requirement by Medicare that you're meeting these timely goals and
You
these
already
timely
had.
diagnosis, we are at this. Um, I guess from my background, I almost treat structural like heart failure, because heart failure is so big in the Medicare world right now. Like,
Hmm.
your readmission rates, making sure you have care navigators, and making sure these patients are treated timely. And I feel like structural is kind of like that in my world. So this shows that we're doing what we need to do to treat these patients and that we're meeting this goal. So it was kind of exciting to see this
Yeah.
and to show this to all of our team, saying, we're doing what we're doing. Some days it doesn't feel like it because you just
Yeah.
see the sickest of the sickest sometimes. But this shows that we're treating these patients and giving them back their life, and their quality of life is improving. So that was exciting. I was impressed. I didn't think we were going to be above the national goal. And
Yeah.
when we are now, so the American Heart Association, after this initial year, reached back out to us and offered us another 5 years to be part of this study. So you do get a grant every year to be part of the study, and you continue following these patients that haven't been treated yet to see.
Hmm.
And they also include moderate AS in part of the study. So it'll be interesting to see how fast those patients progress into severe AS. So I'm
Yeah. And
excited to
I
keep doing this.
And I think what you just said, the moderate to severe moderate population, it's what's coming next. We know it progresses, and we know you know, there's a large group of people out there in the population that, are continuing to get older, their disease is progressing, and what I'm hearing is you're using this to kind of get a little surveillance on them ahead of time, to just know where we're at, know what their plan is in place. Do you find that being able to be a little bit more proactive that way is just setting you up for looking at things like capacity and getting patients in and prioritization, some of those things that might be coming down in the.
Yeah. So because these patients are in your system, and now you've got them set up in a filter, especially these moderate AS patients, as you follow them for the next 5 years, I think that being that proactive part, we can show the volume that's coming our way. And also, once that patient crosses over severe AS, it's you've already planned for that, because
Yeah,
you can reach out to them, you can reach out to their primary care or their general cardiologist,
yeah.
because you've established them in the system already. So it's a lot less legwork on that side when you've been following these patients. So I think that'll help show us the volume too that's coming in, like you said,
Hmm.
and help us prepare, and from getting more staff or getting more OR time, or even getting, if you're looking at increasing your interventional cardiologist or your CT surgeons, because those patients not are just TAVR. It includes all of the AS patients, whether they're a SAVR or a TAVR. So
Hmm.
it helps both branches of the structural world.
And before we go into kind of like, what have you learned from this? I was just curious, coming into this, were you a tech savvy person? Did you feel like you knew how to go into these lists right away? Or did you look to Ignite to also kind of help with our operations team to work through this? What was your experience when you first had to go and start doing the doing? Like, what were you
Doing the
thinking?
doing.
Doing the doing.
Yeah. So when we were initially looking at these different companies, Ignite just had the most robust and comprehensive support. You're not calling a 1-800 number if you're struggling to figure where's this filter, or, what did I thought I deleted a patient, or, you actually have contact. We do weekly, when you initially set this up, you do weekly conferences with your support staff. Lynn and Kaylee are with our system, and it's just incredible how much support they give us. I've been through 6 or 7 EMR epic go lives,
Yeah.
and everybody knows how that goes, because sometimes you're like, where is somebody? And you're trying to do something,
Anybody?
and you're like, I need help now. So this is never like this. The
Yeah.
process and the support is incredible. One of our management team, he's been through another go live with a different type of system for another project, and he was like, hands above the best. And he is not a tech savvy person at all. I'm slightly tech savvy. Um,
Mhm.
I I love my computers, obviously. Once you learn Excel, it seems like you get more tech savvy, and all of us are using Excel these days. But I have actually stopped using Excel because I have this platform, which is huge, huge for me.
Yeah.
If you know me, I'm a post-it note Excel. I have a wall, thing on my wall with all of our patients. So slowly getting rid of that paper process has been huge for us, because the platform itself, if you have a checklist that you use every day in your program, Ignite will build that checklist right into the system for you, and you can fill it out and print it. So that is the process that we are transitioning to, and getting rid of our
Mm.
daily checklist that we use for each patient. So that's huge, especially when you add more people to your team. The
Yeah.
platform itself allows for communication too. So it can be your primary point, and the support to help you do that is there. You don't have to worry about like, oh, okay, they built this for me and now I don't ever talk to them.
Yeah.
So we're, almost a year into this, and we still meet bi-weekly. And sometimes it's 15 minutes, sometimes it's 30 minutes, sometimes it's an hour. They're very flexible, and, and it's kind of geared towards you. So like if I run into something during the week, I can literally email them even and say, hey, I need help with this. If it's something that can wait, you can add it to your agenda that you already have set up, or they'll answer it right then and there for you. So without that support, I think it would be overwhelming, very overwhelming.
Yeah.
So that is one reason we loved the Ignite CardioCare platform, because of the support.
And I'm glad to hear that you said something that you get your time back, because that's, I think, as a clinician, no one has enough time in their day, right? So to say I get some time back for my patients, I think that's huge. So
Yeah.
I'm glad to hear that. Looking back, like just it kind of like where you started, how you've implemented cardio care. Tell us about some of the lessons you learned, some things you may have done differently. Um, how has this changed your process just as a program?
Yeah. So with the CardioCare platform and these filters, it has literally reduced our diagnosis to eval time from 3 to 4 weeks. As that initial slide showed, some of these patients would lag in waiting to be seen 2 months sometimes.
Yeah.
So in creating that direct line once they're identified and reaching out to that provider, that has definitely huge reduction in our diagnosis to evaluation. And that direct provider communication is what drives that result. Um, so now once they're seen, we can get their workup done, and whether it's TAVR or SAVR, within 2 to 4 weeks. That's huge. We were kind of floating around between 6 to 8 weeks at one point. And we were working to shorten that, and this platform allowed us to do that with that direct provider communication, um, and that weekly cadence. That is the other part, because initially you're like, how do I build this into my program? Where do I
Yeah.
put this? And we literally block it out in our calendar. You find a half hour here, a half hour there. You can break it up into small pieces. You don't have to even block an hour or 2 hours. Just a half hour once or twice a week
Yes.
is really all you need. And that allows you to build it into your program And then, as you know, everyone, we multitask. You're doing one
Yes, we
thing,
do.
you're on the phone working something else, but you can do the platform while you're doing other
Doing
things.
other jobs, other work.
Yeah, because you get used to using it and where things are on the platform. So you're able to add it into your daily multitasking as we all do.
Yeah.
Yeah. And
What would you,
go ahead.
I always think of like if you're brand new, like think of where you were when you started with us. What's a piece of advice that you would give a new coordinator that's just starting out with us?
Uh, you know, Kristen is a new coordinator with us. And I remember, when I see her working things through, I mean, 8 years ago, started doing this. And it's just so overwhelming because, I didn't realize it until Kristen had come on. Like our acronyms that we use are so different than
Hmm.
anyone else. And they're just like plain language for us. And, looking back, I was like, oh yeah, I remember trying to learn what, PV is and MG and how we use it in our daily work. So Kristen has started her training with the platform, and it allows her to put it together. It creates that whole picture for somebody that's just coming onto the program. So even if you're new to structural, using this platform, you can see it all together in a simple language, simple English in buckets. And that allows you to tie it all together. And then it starts making sense. She's already reached out to a primary care. We've done an outreach referral, which she's like, oh, this is awesome. I impacted a patient already, just starting out as a structural coordinator. So I think if especially when you're alone, a lot of us are in these structural programs with one person or two. So just knowing that the support is there and breaking it down into small pieces, that'd be the advice I would give a new coordinator. Because it's teaching you as you go also, especially when you're new and putting it all together.
It's a lot. Like I would have said it better myself. Um, it is a lot. So I love that the way you've approached this. Um, Last question for me is where do you see yourself going with this going forward?
So CardioCare platform, not only it has AS, but it also has the mitral and the tricuspid. We've also extended out to our atrial fibrillation because then you also pull in heart failure and
Hmm.
LAO. So I think the platform for the system is going to grow for
Yeah.
each area that we work, which is nice because most structural programs are adding in the mitral and the tricuspid because we've got the clips and now we're getting the valves. So this platform will help you find those patients because those volumes are lower, but this will help you keep a steady volume, I think. And so I'm excited to see where that brings us and to work into those other buckets slowly now that we've got a system down for our atrial platform. So that's exciting. So that's where I see our program. And then our continuation American Heart Association is exciting. Um, I would highly recommend it to any valve coordinator to reach out to American Heart Association and get involved because their support is really good too to get you going on this platform because they're excited to bring this data to ACC and to cardiology everywhere to show yes, let's treat aortic stenosis as a primary disease. We do, but we don't. I feel like sometimes because we see the other diseases, diabetes, kidney failure, heart failure, but to me, it all ties into that heart because, as cardiology says, it's without your heart, what do you have?
That's
So
right.
I always think of that
It's-
because it truly does affect every part of a patient's life if they're having severe AS and they're symptomatic and they don't know what to do because they're just like, well, I
yeah.
didn't know it was my valve, or well, they said they'd watch it, and putting that at a forefront for that patient helps them feel like they're in control again.
Well, thank you, Cindy, for sharing not only about yourself, but about the journey with us and your program. You're doing such amazing things. I really appreciate your time. We wanted to make sure we left some time at the end for questions from the audience. So I cannot see them, so I'm going to ask Our helpers behind the scenes, do we have any questions from the audience?
We don't have any questions from the audience.
Okay.
There seems to be a technical problem with the chat, so don't be shy and raise your hands, please, to ask your question. We'll have to investigate the technical glitch there.
That's all right. I'll just tell you a little bit about our program. As we said in the beginning, we do have, we have 1, 2, 3, 4 hospitals in our system. We only do our structural interventions here at our main hospital in Omaha. Initially, we started out as a very small program, 40 TAVRs the first year, 60 TAVRs the next, 90 the next, and then we did jump up to 130. And now we're going to sit hopefully right around 140, 150. So that is our goal throughout the next couple of years, is to keep that at 150 and up. So with myself, we've added another valve coordinator, we've added a nurse practitioner, and it's been amazing. We have 2 interventional cardiologists, we have 3 cardiothoracic surgeons. Our main cardiology group, we have 1, 2, 3, is over 20 plus clinicians. So we have a lot of cardiology support. And then also our primary care system is huge. But reaching out to them directly, I think, really affects systems more than we realize. And I never thought of it, because I always thought, they'll send it to general cards. But general cards, as everyone knows, is so busy. They're just packed. Yeah, they're packed because there's so much technology. And so patients are coming in younger and sooner. But where do we put them? And how do we divvy out that work to let the general cardiology see more patients? So that's helped that process, I think. And it's good to see in a system and see that growth, especially from when I started. I just did Watchman's. TAVR scared me for a long time, but then I had a coordinator I worked with, and she was like, "You got this." And she just kept pushing me to learn more about TAVRs and that structural side, because I was like, "Oh, I'm EP. I just do Watchman."
Yeah.
But now that I'm in it, it's something I can't think about what I would do if I don't do structural. It's been a great progression into it. So, and as the technology, it amazes me every day what biomedical engineering is coming up with these days. So when we did our initial evoke, you're just like, wow, we're really doing this. This is a transcatheter tricuspid valve, and you have transcatheter mitral valve coming out. So the progression of technology is huge. And I think you almost have to have a platform, especially like Ignite and CardioCare, with the support to help you find those patients and keep that direct line of communication with the patient and the provider.
All right, we do have a question from the audience, and it asks, can you please tell us more about the integration with your EHR, or if you are managing patients through both the EHR and through the CardioCare platform?
Yeah, so the integration, we use Cerner. So it took, I think it was about a 3-month process, but it's mostly on the backside. So as they're working in that on the backside, you are learning about the platform with your education, like Lynn and Kaylee. For me, you're learning the system while they're working on that connection. It took a little bit, as you know, IT and letting another platform into your EMR takes a little bit of work, but it actually was pretty seamless. We had very few hiccups, but a lot of that's done on that backside. So as a coordinator on the front side, I was learning the platform before we even went live. And then once you go live, you're a little more comfortable with the system. And then working into our daily practice, initially, you're trying to figure out where to put it, what day would work better, when, and trying not to use, your lunch or your after hours or coming in early. So we just kind of broke it up into those half-hour increments and, built it into our calendar twice a week.
All right, another question.
Oh, go ahead.
Once patients have their TAVR, are they then referred back to Gen Cards? I think there is hesitation from our Gen Cards that if they quote unquote give up their patients to structural, they won't come back.
Yes, when I first initially got into structural, that was a huge concern. A lot of the general cardiologists were like, wait, what? You want to start with you guys? And now that they have seen us, so what we do is we see the patient. If they have established care, we keep that established care. We see the patient back after their TAVR. Our nurse practitioner sees them in a week, and then we see them back in a month, and then we return them to their general cards. We even for their 1 year, they go back to their general cards. We have one of our schedulers that helps us out from our cardiothoracic side. She does our KCCQ12s. We give her a list of every month, our 30 days and our 1 years that, even some of our 30 days, we have been returning to their general cardiologist, especially for our outreach sites, because we do have a couple that are a half hour to 2 hours away. And we'll reach out to that office and say, hey, their TAVR is scheduled for this date. They need a 1 month and they need a 1 year. And they've been very receptive to that, knowing that you can show them that you're going to return this patient back is huge. And we're okay with that because that keeps the referrals coming back to us because they know we're not going to keep that patient. And you don't have the room to keep all these patients after they're treated for years and years. So, and that's kind of how we brought it up to them too. Like, no, we don't want to take your patients away. We want to treat them, continue their follow-up. They've already established with you, they know you. So just keep referring back to that. Like, we're here to treat them and give them back to you.
I think that wraps it up for the questions.
All right. Well, thank you everybody for joining us. Thank you again to Cindy for sharing.
Oh
And
yeah, thanks for having me. This has been great, and I hope more coordinators out there watch this. And like I said, reach out anytime to CardioCare Ignite platform if you guys. It does help our daily practice.
Great. Thank you, everybody.
Thank you.